Hello and welcome to Module 5. Module 5 is about sedation, immobilization, as well as hospital dentistry. This might be the module many of you are waiting for because it talks about a lot of things that maybe some of you are not doing in practice currently. Learning objectives, we will go over what the sedation continuum is. We will talk about OR indications and what really life looks like in the operating room, what hospital dentistry looks like, what are our workflows there. We will go over alternatives and we will talk about documentation, which is very, very important in hospital dentistry as it is for regular dentistry. How to choose treatment options. So, sedation is a continuum, right? Even if we are attempting to only do oral conscious sedation or what's called minimal sedation, it's very possible that our patient can slip into moderate sedation. If you're trying to do moderate sedation, it's very possible patients might slip into deep sedation, and so on and so forth until general anesthesia. So we have to be very careful about how much medication we are using for these patients, how well they're being titrated, so that they stay within the treatment category that we originally intended. And that's why in many states now, even though you're only doing OCS, they want you to be prepared for what happens if the patient slips into moderate sedation. You should know how to use an airway in your practice if you're just doing oral conscious sedation. So this law is different amongst different states. I live in California, and this is the kind of law that we have over here, which makes a lot of sense. The choice between the different sedation options really is based on airway risk. I know I have talked a lot about airway in the past couple of modules, but I will mention it again over here. If patients have complicated airways, they will not be good candidates for any kind of sedation or operating room dentistry where they receive general anesthesia. Cary's burden, failed office attempts. In my book, I always try for at least 5 attempts of desensitization before I need to make referrals or I need to consider maybe general anesthesia for certain patients. But everyone's books look a little different. Everyone's time and availability is very different. You have to figure out what makes sense for your practice. How many failed attempts would you tolerate or would you attempt before you send a patient over to another provider or you send them over to the hospital? Mobility issues is important to consider. Patients with severe anxiety and behavioral concerns. We have seen patients in the operating room before who were just extremely, extremely anxious about receiving dental treatment while they were awake. You have to consider medical comorbidities, and we went over that in Module 2. And of course, procedure complexity. You also need to remember that in operating rooms, there's very limited time. There's maybe an hour, hour and a half for dentists as well as residents to complete treatment on a patient. They are not really going to do a whole lot of molar root canals, same day crowns. Many hospitals don't have those kinds of resources. Most hospitals have focused on taking teeth out, getting the cleaning in, completing all of the fillings. If you find a hospital that's able to offer implants, same day crowns, root canals, that is absolutely fantastic. But those hospitals are pretty rare and not present throughout the country. And of course, we have mentioned this before, but patients can definitely be turned away from the hospital. I have seen plenty of anesthesiologists raise serious concerns about patients with special healthcare needs when they're being seen in the hospital. They will ask you very, very directly, why is this patient being seen at the hospital for dentistry? Why can't you try to do everything possible to keep them out of the hospital because their airway is super duper tight? What if I cannot bring this patient back after anesthesia. And we have to tell their family that it was because they were getting a dental cleaning. Anesthesiologists have actually said that. And from their perspective, that makes complete sense, right? Of course, you can always look at it the other way and say that no, dentistry is important because it's quality of life. We're trying to improve their quality of life. And sometimes, if a patient is absolutely not compliant in a dental office, operating room dentistry is the only way to go. What do you do? Again, this is a potential gray area. There's ways to debate both sides of the coin. But again, that's why I would say that we try everything possible to keep patients from going into the hospital because sometimes a hospital might not accept them. Who is the decision maker? This is key no matter whether you're seeing patients for sedation or operating room dentistry, whether you're stabilizing them or not physically, or you're just kind of seeing them for routine procedures in the dental office. We have to determine what is their decision making capacity. This is tricky for someone who is starting to slip into cognitive decline. If you're starting to notice that there are some issues with mentation, then you have to start engaging with their family members. Again, figure out what is the most HIPAA compliant way to do that. But you might have to involve other people to understand if this patient is able to make good decisions about their treatment or not. Some patients might have a conservator, they might have a guardian, and these terms can be defined very differently based on which state you live in. So you have to understand what the laws are in your state about this. Some patients have surrogate decision makers. So even though they are the main decision maker, they have other people who help them with decisions. It's also called supported decision making. And even if a patient has a conservator, the conservator is supposed to give a lot of priority and importance into what the patient wants before giving an approval for some kind of treatment. Um, and a power of attorney, which I think most of us here understand it pretty well, is basically a legal document where a person who has the capacity of decision making, they have willingly entered into this contract and said that they delegate a specific agent to now make decisions on their behalf. And it could be decisions only related to healthcare or only related to finances, or it could be both. So we only worry about the healthcare stuff, but we actually also need to worry about the financial aspect because somebody has to pay for healthcare too. So I have run into several situations where healthcare decisions are made by one child and the financial decisions are made by the other. So you have to be on board with both of them and be in touch with both of them. Healthcare providers obviously need to review paperwork before submitting HIPAA compliant information to any third party that is not a patient. So if there's a conservator, a guardian, some kind of power of attorney, we need to be confirming who these people are by reviewing their paperwork before sending any information across or responding to requests for information from us. That can be very tricky sometimes because sometimes we will get a call or an email from a daughter or a family member who is asking about how the dental treatment went, what did we do, and then we find out that they are not the power of attorney, so we cannot submit information. And when our office tells them that, they get very upset. But we have to protect our patients in any form. So we just have to do what is right by the books. So sometimes it makes for difficult conversations between people. Case study. One of my very memorable patients had said this: Doc, I did a stupid thing. I listened to my friends, and you have to just wait until you see these pictures. It's so fun, so fun. But we will first go over medical history. This is a 74-year-old female who has occipital neuralgia. She has myelomalacia and she is on, unfortunately, a do not resuscitate status that she signed for herself. She has osteoarthritis. She has had multiple fractures of the spine. She has had multiple vertebral repairs. She has been on alendronate, a bisphosphonate in the past, but that was more than 10 years ago. So this patient is just in a lot of pain, lots and lots of pain. And you can think about her physical disability as just being a very, very limiting factor in her life. She is pretty much completely bedridden most of the time, right? So life is not easy at all for this patient. So if you have any ideas when you look at this without me kind of giving it away, that's awesome. But if I would have seen this picture without understanding what she had done, I would have been completely perplexed because it just looks like nothing I understood, right? So it turns out that she had some teeth missing. She has actually broken teeth right in the front, and she was doing video calls and FaceTimes, with her friends, and starting to get a little embarrassed. And her friends were like, you know what? Why don't you try those DIY veneers or something that you get off of CVS? And she was like, oh my God, I should totally do that. And she did that, and she added too much of that material. It was very, very hard acrylic material, and it went everywhere. It just went everywhere. And we don't have a picture of what her smile looked like, but basically, the material was plastered on most of her 4 or 5 front teeth. So it looked really strange. And she had had that for almost 2 weeks before we could go in and see her. Our schedule is just extremely packed, so it becomes difficult to make time for patients on an immediate basis, unless they're true emergencies, right? She was really, really visibly upset because of this, because you can imagine that this is not fun to live with for anybody. Luckily, she was not in any pain, or it did not look infected, but it it was definitely something that she wanted to have us fix right there and then. So, how would you proceed? You've just heard the medical history, it's pretty complex. Imagine this patient at your clinic. She is also a heavy set female. Her BMI is easily over 35, maybe 36 or 37. Where and how would you see her? Remember that she's had multiple vertebral fractures. She has all of the spinal issues. She is on lots of chronic pain medications, very strong pain medications. Extremely sensitive spinal cord. How would you see her? Would you transfer her? Would you not transfer her? I hope you already have an answer in your mind for that. Would you request any specific medical consults? Would you figure out whether it's okay for us to take teeth out because she's been on a alendronate almost 10 years ago? Do you have concerns for anesthesia? She did say she had like an allergy to carbocaine. I don't know if you guys read that. Not carbocaine, sorry. She had an allergy to Lido or something like that, and that carbocaine is okay. So, do you have concerns regarding anesthetic usage? Any further questioning required? Would you refer her to sedation, operating room, etc.? I'm going to give you a few seconds to think about that, and then I will jump into what we decided to do. So, even though this patient has a lot of medical comorbidities, and some of them are pretty significant, from a dental perspective, she's actually pretty straightforward, right? So the alendronate doesn't concern me because it was taken almost 10 years ago, and the half-life on alendronate is also about 10 years. So it just does not make sense for us to wait another 10 years to do treatment on her. Some of those teeth look pretty bad. They definitely do need to come out, but trying to do it in as easy a way as possible without hurting the bone too much, without being too traumatic is what is key. Um, if she's being seen in a private practice, I would not try to move her out of her wheelchair. Keep her in her wheelchair, treat her where she's comfortable. Do not try to get into transferring someone who has a BMI of over 30. Anyone over 30 is really should be a no-no for you to transfer. Um, she does not need any anesthesia or sedation or operating room procedures despite of her medical complexities. In fact, because of her medical complexities, she would be actually the worst patient to be seeing in an operating room situation because anesthesiologists hate seeing patients who have all of these spinal injuries, right? They are not good patients to be seen in the operating room. So you want to try and do things in a dental practice 100%. It turns out this patient was extremely anxious, which we could not gather from her medical history. It's what we found out once we started taking x rays. And luckily, we had a full time caregiver there. With the caregiver, patient did great. Her blood pressure was under control. She did pretty well. We got that DIY thing out. She started crying. She was so happy that it was out. We planned treatment. We planned upper and lower partials for her. And then we proceeded with our day. She was thrilled, absolutely thrilled that we were able to get it out. So, what we really try to accomplish with our patient is try to minimize stress, and we just did a very small thing the first day, which was we took out that DIY thing. I don't know what else to call it. We did not do any extractions. I did give her anesthetic. I gave her carbocaine because that's what she wanted, and she did great. The next appointment would be for extractions and some more extensive treatment, but I also feel she's going to continue doing very well for those subsequent appointments because when she was in her comfort zone, her compliance was really good. And that's what you have to try and accomplish for these patients, even in private practice. What are some alternatives that you can offer to patients? Protective stabilization, we went over that in a previous module. Physical supports. So for this specific patient, we used a neck pillow. We have also used head pillows that help keep the patient from moving their head too much for it to be more comfortable for them. Nitrous would have actually worked great for her had we had that option. We don't carry nitrous with us when we do home visits, but it's definitely something that most of you have in your dental office, and nitrous would actually be fantastic for her because of her anxiety. And if you're using any of these stabilizations and supports, of course, I've already mentioned it before, you do need to have consent forms and appropriate team training. What does life in the OR look like when you send patients out? I have seen a lot of patients really downplay the importance of going to the OR. Many of them don't completely understand that they are going to be put completely to sleep, and there is a very good chance some of them might never make it out of there because that can happen. You're basically putting your whole life on hold for those couple of hours, and it can be very difficult. Anything can happen during that time. A lot of patients don't understand that, and if they are high anxiety, they might just say, doc, I want to be put to sleep, I want to be put to sleep. and they have convinced themselves that that's the only way in which they can get treatment done. So, talking them back from that can be a little challenging. It's possible, but it's just very challenging. For any patient who ends up being sent to the OR, you need to get a detailed history and physical from their primary care physician. This can take a few weeks depending on which hospital system you're working with. Typically, these medical clearances or medical consultations have to be faxed to the doctor, to the primary care physician, and then they will fax you back a history and physical, which is super duper detailed. It's like 11, 15 pages long, full list of medications. And it's like a system review of like what's going on with GI, with cardiac, with the renal system, everything. So it gives you a lot of information. I also typically request this for any patient receiving IV sedation. So just as an FYI, you can request it for any patient. Patients have to undergo a medical consultation. They have to undergo evaluation by an anesthesiologist. They have to follow very, very strict fasting guidelines. I have definitely seen patients eat something unintentionally before their appointments, and then they have to just go home because eating something means that you have an aspiration risk, so you are a total no-no for receiving general anesthesia that day. Some medications might need to be held. I'm just mainly thinking about patients who are diabetic at this point. Sometimes their medications might need to be stopped either the day off, the morning off, or the night before. And again, that is something better done and handled by an endocrinologist rather than you having to do it. So get the appropriate consultation from them. Airway exam, even though it is done by anesthesia, if you are sedation certified, you know how to do an airway exam, you would do it. You would get a Malam-Patti score, for example, and see if this patient is a good candidate for receiving sedation. I think it just makes sense for all of us to learn how to do it, because if you do it in your office and you find out that this patient is not a candidate, then you can just skip the referral to the operating room. Many patients will require some kind of OCS or IV before operating room procedures. So what that means is typically if a patient is being sent to the operating room because of compliance or because of behavioral issues or lots of failed dental appointments in the past, then we have to give them a stronger dose of benzodiazepine, or we need to start an IV before they can actually cooperate and comply to reach the operating room. So keep that in mind when you are sending patients out to the OR, because that might need to be done by you, or you might need to put in prescriptions with their primary care physician to have that managed properly before they reach the OR. Pre and post documentation, super important. Um, there are certain billing codes that need to be there when patients are being sent to the operating room. Of course, I'm assuming that most of you are not hospital-based dentists, but hospital-based dentists have a very, very clear template or guidelines that they follow, and they always have the same codes, the same justification criteria for all of these procedures, because typically when patients go into the OR, their procedures are being covered by their medical insurance, not strictly dental. So following those justifications and codes becomes pretty critical. And that's about it. That was a very short module, and I will see you in the next and the last module of this course. Thank you so much.